how well you prepare, huh? Especially with tech. There you go.
Right, as Dr. Burnett already pointed out, we have another view of the Tetons. This is our inpatient days. We took a big dip in January, but it rebounded a little bit in February, which is a little surprising because it's a shorter month. I guess we were kind of busy on the floor, right, Piggy? Okay, next slide, Jen. ED visits and urgent care. You can see there the ED is in blue. Urgent care Pinedale is the orange line, and urgent care Marbleton is the green line that just disappeared. Back up the truck. We can stay on this one. Yeah. So this is outpatient visits, and we do see a little bit of a decline there for the outpatient visits, and we're back to the ED. I thought it was just Jan trying to pull my chain a little bit here, but so yeah, we can advance or attempt to advance one or two. And there we are with EMS, and we continue to struggle with the not billable runs. You can see our billable runs dropped, or unbillable actually went up slightly, and the percentage, which is the dotted green line of unbillable runs, is up to, I think that's a 69% or 65%, somewhere in that range. So again, a lot of the non-billables are EMS will get called out and the patient will refuse transfer. That seems to be the majority of them. So, and it's not always the patient that calls in. It might be a neighbor calling in saying, I think my neighbor's having a problem. We need you out here. And they get out there and the neighbor is fine and refuses transfer. So that's what causes a lot of those non-billable runs. Next slide. Just push it once. There we go. Imaging volumes, at least slide 1 of 2 on imaging volumes. Ultrasound was up, and I thought that was odd. And when I brought it up at the, was it the manager meeting? What the tech had to get her recertification. Oh, I'm looking at the wrong line. The mammo's blue, right? That's one I was talking. I couldn't read it from here, so my apologies. So the mammograms, and that what was her name that needed the certificate? Sarah needed recertification. So we had a bump. A lot of employees and other people that were aware of that she needed some additional tests came in and got their mammos done. Bone density fairly steady up at just a touch, and then ultrasound actually declined just a little bit. But overall volumes in imaging were fairly good given the short month. Next slide, please. We're going to have some theme music in between these slide changes. Lab tests surprisingly up a little bit as well. Again, February, I read somewhere that it was the first time in 40 years that February was a perfect month. The first was on a Sunday, the 28th was on a Saturday, and that happens like once every 40 years. I don't know why I brought that up. I should have done that between slides. But yeah, there were exactly 20 working days, and we actually saw a little bit of an increase in volumes in the lab. Next slide. This one clearly demonstrates that February was a shorter month because we were still full, and you'll probably see that on the next slide. But fewer patient days because there were fewer days in the month. Next slide. There. You got it somehow, Jan. Very good. So the daily census is the blue line up at the top there, and you can see it actually increased a little bit, even though our number of days went down. And that's, again, a reflection of the number of days in the month. So we have some seasonality in our data, but we also have some changes month to month, depending on how many working days or how many total days there are in a month. So clinic visits are going to vary a little bit by the number of working days. Hospital inpatient, long-term care, that's going to vary by the number of calendar days. And we see that pretty clearly on some of these slides. So that's also why our revenues vary a little bit from month to month, depending on those working days and calendar days. Next slide. And the clinic volumes, as you can see, dropped off a little bit. We do have some months where the total number of working days is only 19. Those are very few. 20 is not uncommon. It's a pretty common one because some of the longer months have holidays in it. So you got to subtract those out for the working days and the weekends. But this shows a slight decline from January. And I think we had 21 days in January. So just a 1-day decline, but it makes an impact on how many people we see in the clinics. Next slide. Yeah, I really didn't want to show this one a whole lot, but I hate to be the bearer of bad news. And it seems like that has become my norm, except for last month. We had a pretty significant decline in the net patient revenues. Even in the gross revenues came down a little bit, but it was a lot steeper on the net patient. And I'll explain that when we get to the financial numbers page, which may, oh, I don't think it's the next one, but the one after that. So you can go to the next one. So this is our AR data, and the darker blue line is the total gross dollars, and that's on the left axis. And it grew a little bit, about $100,000 from the prior month, but a lot less steep than we've had all year. So to me, that means we're catching up a little bit. Unfortunately, the days, which is the days in AR, which is the light blue line, continues to climb. And part of what was driving that is the ED professional fees that we voided and rebilled, or in the process of rebilling, and I'll describe more about that coming in a few minutes here. Next slide, please, Jan. You might need to zoom in on this one, Jan, and scroll down as we need to. But... Oh, there we go. Let's scroll back up to the top just a little. So our gross patient revenues were impacted, and subsequently the net patient revenues as well, by the ED pro fee adjustment that we made. And I've mentioned this a couple of times, but when the charge master for the hospital was created and implemented in August, in the ED, there are two components to an ED bill. There's a technical fee, which pays for the nursing time, the space, all that kind of stuff. And then there's the professional fee, which is for the doctor's time. The professional fees typically are about 1/3 the value of the technical fee. So if you have a $1,000 technical fee, you might have a $350 professional fee. Unfortunately, when the charge master was implemented, those two fees were given the same charge. And the difference between the revenue code is what differentiates the two. I don't want to get too technical, but there is a differentiator. So you have the same charge number, 99281, but there's a revenue code 950 for, I think it's 950 for the physician fee and 750 is the revenue code for the technical fee. So we were way overbilling. Ghosts are visiting. So we recognized that, and the right thing to do was to correct that, not only going forward, but for those professional fees that had already been billed since August. So we had about 1,200 accounts to be rebilled, and the gross amount of void was just over $2 million. That's what's impacting the gross revenues. To rebill, we have to do all those manually. So the void was a little easier because we could run a routine that voided all of those bills. Can't do that to rebill because they have to be retouched by coding and done manually. So a lot of that revenue, some of it showed up in February, but most of it's going to show up in March. So while February is very poor from a gross revenue standpoint, I have my fingers crossed that we'll recover all of that, and March will be a much better month. So the roller coaster ride continues, but it's like the technology in the room here. We're all adjusting to it. We're all trying to figure it out and get it in the right place. We're still doing that with the setup in Ocean, and some of the issues that were either overlooked or done incorrectly. Most of it was done fine, but there are a few things that clearly have a significant impact that weren't set up quite correctly. So we're fixing it, and I'm not aware of another issue right now. I've been talking about this pro fee thing for a couple of months because it took that long to figure out how to fix it and how to get the routine written to do the voids. But I'm not aware of any significant setup issue that we haven't already addressed. So hopefully this is the last time I have to say something like that. On the contractual allowances, a little bit better, but still a big impact. It's a 1 point. Oh, I'm looking at the wrong number. Yeah, the contractual allowances is a percentage for quite a bit higher for the month, and that's tied to that corrections. And the resulting net revenue that's what we expect to collect on everything, except that we're short all those $600,000 of ED pro fees. So that should come back down next month and improve our net patient revenue, but it's a very weak net patient revenue this month. Now, the other thing I want to mention about allowances is we got our survey okay for critical access on February 26th. So starting in March, even though we're not billing as a critical access hospital yet, we will be, and we can start taking a little bit less of a deduction, actually quite a bit less of a deduction for those Medicare claims that start February 26th. And just to give you an idea, what I'd previously been using in my estimates, that we would get an inpatient rate of about $4,250 per day. So as a critical access hospital, as I've mentioned before, we get paid on a per diem versus a case rate, as a PPS hospital. So you're here 1 day or 5 days, it doesn't matter. You get the same case rate. But as critical access, we get paid every day, a specific rate. I've been using 4,250. Our current estimate is $6,700 per day for that inpatient rate. I have a meeting on Friday to finalize some of these things before we send it off to Noridian. I have my fingers crossed that they'll accept what we send because it's pretty detailed. On the outpatient side, I was using 60%, and we're closer to 70% reimbursement on the outpatient side. So if you use a CT scan as an example, and I'll use just round numbers, we charge $2,000. As a PPS hospital, we're getting paid about $200. As a critical access hospital, we would get $1,400. So that's how significant the change is from PPS to critical access for a hospital this size. And these rates are very high compared to most critical access hospitals, but that's because our volumes are so low. We still have to meet staffing requirements in the ED, in the lab, and things like that, even though we don't have the same volumes that a larger hospital might have. So that's why our rates, if you've seen other hospital critical access hospital rates, that's why ours seem a little bit higher, because of the lower volumes that we have with essentially the same cost. So moving on to expenses, can you scroll down just a little bit, Jan, to see the bottom line on the expenses? So we were about 10% favorable on our expenses for the month. You can see salaries and wages there. I can't read the number from here. I think it says 12% favorable. But again, if you go down 2/3 of the way to contract labor, we're unfavorable there. And that's kind of the trade-off. I think we're down to 6 travelers in long-term care. So we're making progress, even though it doesn't look like it by the number there. But we had some late invoices that came in. It should be less than 194,000 going forward, because I think we've caught up on the invoices that were a little bit late. Professional fees were also a little bit higher, and that actually has a unfavorable variance. And that's because we had some late Cardinal invoices, and Cardinal is who we pay for our pharmacy coverage. And it's mostly around that. There were some drugs on there too, but mostly for the pharmacy coverage. The locums looks really favorable. That's because when the Apogee contract was set up for the hospitalist program, there was a clause in there that basically made us set up a month's worth of payments in advance, and after 6 months we get that back. We got that back. I might not be saying that exactly right, but that's kind of the effect of it. So we got $160,000 credit back from Apogee in February. So that's why the locums looks so much better than what we had budgeted. A couple of other large variances, the supplies, that continues to be driven by food costs mostly. Those food costs keep going up. You probably see that in your own grocery bill, right? So we just have a bigger bill than you have at home. At least I hope we do. Interest expense, we had missed some interest payments on the line of credit, and those come out through ACH. So somebody has to be reconciling the bank statement to find that particular expense and record a journal entry to recognize that on her income statement. And Michelle hadn't quite caught up from her maternity leave, and so we had a couple of extra months of interest expense that we had to include this month just to get caught up. But we are caught up now, so we shouldn't have that variance going forward. So in spite of the savings on expenses overall, we still have a $2 million loss for operating income. Well, scroll down a little bit more. And the mill levy, continues to drag just a little bit from what we have projected. The other pieces of non-operating income are much smaller than the mill levy piece, but that's where we ended up with a $2 million loss for the month, at 8.5 million or so. I can't read it, 8.1 million year to date. EBIT is a little bit better because we removed the depreciation and amortization line. So yeah, a very difficult month to come and report, but I hope this is the last one with significant adjustments. We talked about the balance sheet, and we talked about how our payments should start to improve once we can bill as a critical access hospital. Questions? We have a long-term care component too that is done here. I got to put those eyes in the back of my head again. Yeah. And I'll let Don come up and address those slides if she's willing.
He's coming up. Just Steve mentioned supplies. The increased census in the nursing home is a big part of what's driving the increased food cost. So if you think in terms of historically, we were doing 32 to 36 residents. Now we're doing high 40s. That's a significant increase. So when you look at the supplies and being related to food, it's because the number of meals that are being produced are significantly higher than historical averages showed.
Yeah, thanks for clarifying that, Bill.
In regard to overall supply costs as well, I just have a quick question about Vizient. Are we fully capturing all of our savings through Vizient now? I know we struggled a few months.
So I would say that the big contracts are in place. There are still a few little details that are being done, but for the most part, we're seeing significant savings as a result of that. Yes.
Okay.
One example that we just did was lab. So lab, we actually are going to be receiving savings because of the Vizient contract.
Fantastic. Thank you. For the nursing home is your top left-hand square there. That's going to show the difference in the Medicare A business. Talked about this a little bit in the past, but you see the difference between January and February revenues being only 3 people. I have to get it right in front of my face. Oh, there we go. Okay, so you see the difference in revenue between 7 and 4 people. And the reason why that is actually can be encouraging is that if we can keep those volumes up, lots of that revenue will go over to the cost side in terms of that swing bed program. So that is going to be a really big benefit, or it could be a really big benefit for the board. And it does beg the question, would we ever want to hold a bed for Medicare? If you've been involved with nursing homes in other states or other places, sometimes they will say, we do not have any of this particular bed available, no Medicare or no Medicaid beds, no private pay beds, because they will hold a bed open, attempting to capture that revenue. Might be something we want to think about, not today, but that's really the only thing I wanted to point out there. Medicare B business, you can easily tell that that's really just catch up from January. See how tiny January was, and then February is a long line, so that just balances out. And on the next slide. Yep, we've talked in the past about leaning into the VA hospice program. And so that was able to give a pretty decent amount of revenue over the last couple of months for our organization. So overall, we are really happy with our numbers, and we just need to look towards future planning as our next set of goals. Thank you, Don. Okay. Anything further? You, Steve?
That's all I have unless you have any questions.
Anyone have questions for Steve? Thank you. Next month, I expect top 40 countdown. Just
I
say
can
it.
do. I've got my Barry White voice going on tonight. So.
Kind of sounds like Casey Kasem to me, but all right. Next up is, let's see, where did I get to? Item D that we added for Jameson, and that would be board governance. Jameson.
Thanks, Madam Chair. I'm just gonna pass down the road. Wyoming Hospital Association, I think we got it in an email, but sometimes I don't always open those or skip through them, but this one I did. And so In there, there is an invitation to their spring meeting. It'll be May 19th. It looks like the way they've got it organized, that one would need to travel to Sheridan on the day before. So there's breakfast at 7 a.m. And then it looks like it gets out a little early, so maybe you might get home by the end of the day. But of note in the agenda, they are two sessions, navigating the boardroom with Jerry Pogue, and it's going to go over some book and a presentation to everyone there. That looks like it would be pretty good. As well as in the afternoon is another discussion with Jason Spring, which is, I'm sure, interactive. And then in the afternoon, there's a legislative open forum. I don't know the guests. I would hope somebody would show up and we could maybe lobby them, twist their arm, tie them up or something. I don't know, but a good opportunity to advocate for our cause. But just would bring that up as, part of being and board governance is to seek out opportunities to make ourselves better and take part the opportunity to go network and do all the things that politicians do. But May 19th is the date, and it's a Tuesday, and it's terrible. It's a terrible day. But if anybody can go, it's all in everybody's radar. Thank you, Madam Chair.
Thank you, Jameson. That is a really good conference too. Went a few years back, and Scott Manis from Help Tech actually presented. It was really excellent conference. So thank you. Okay. That puts us at the end of our committee reports and into leadership reports. So I will turn the time over to Dr. Burnett now for a provider report.
Well, good evening, Madam Chair and board members. I've given you a handout that provides some data on the primary care visits for both Pinedale and Marlton Big Piney Clinic for December, January, and February. The bad news is I don't have any slides for you. The good news is you won't have to wait for slides and Jan will get a break. Okay, looking into the first page, if you look at the numbers for both clinics, as Steve already alluded to, it's evident that the number of patients declined for December, January, and February. As Steve already alluded to as well, January was a little bit short of a month because you started out with the holiday and then the weekend, so you didn't have quite as many days. It's also my contention too, that you always have to deal with the New Year's and people meet deductibles. So that may be an added reason. February speaks for itself because it's a short month, but just in brief summary, if you look at the totals for that 3-month period for the Pinedale Clinic for primary care, that total number is 1,232 visits. If you look at the same period for the Marlton Big Piney Clinic, that number is 1,644 visits. But I'd like to offer some caveats to that. Number one, the Marlton Big Piney Clinic has 2 providers that work 5 days a week and 1 provider that works 4 days a week. In Pinedale, there's 1 provider that works 4.5 days per week, which is not counted in these numbers. And then the another provider that does work 5 days a week, but then the other provider works 3.5 days a week with a half day in the nursing home. So that accounts for some of the difference in numbers. It also points out 2 things to me. Number one is the contribution that the community of Marlton and Big Piney can make and the opportunity that we have there. However, number 2 is we have increased opportunity in Pinedale if we had more primary care providers. And that's something that we've been talking about in terms of how to address that or provide a solution for that problem. But it gives hope. And then later on after the urgent care part, I want to give you another caveat in terms of trying to just compare visits per provider, because there's a difference between what a provider visit is and how much is captured in terms of an And I'll go into just numbers there. But looking at the second page, if you look at Pinedale Urgent Care, the 3 months, it's a similar pattern in that December was busier. It declined. February. However, Pinedale rebounded very nicely in February with increased numbers from December and January. In Marvelton, there was that decline that I mentioned before. Although December was better, or January was better than December, was in February. Looking at that, I'd like to make 2 points. The first one is kudos to Ryan Grove's team because they stepped up and provided urgent care in addition to their ED duties. So that was a very significant contribution because we didn't have somebody fulfilling urgent care at that time. The other thing I'd like to point out and give kudos is to Tara Ryan, who's only been with us for a short while, started in February. But if you notice, she saw 223 patients in February, which is outstanding. So good job for her. Like I said, if you look at the numbers, they're declining a bit. And I'm not going to go into the ED visits and inpatients. Steve's already covered that. Those are pretty much more self-explanatory on a day-to-day, month-to-month basis without the caveats that I mentioned in terms of the providers. One thing that I found interesting, and this is some information that Dr. Hasty gathered in his initiative, is based on him trying to move forward with trying to provide an equitable solution moving forward for us to increase our revenues, but looking at both how much we currently charge and how much is being how much is being attributed to each provider. And I'm going to give you some numbers in a minute. And what I have was a compilation of numbers from August 4th to January 4th. And then by comparison, I have January 5th to January 30th. And there's some key points I want to point out there. As you'll see soon when I talk to you, there will be, there's a pretty good increase in the revenues per provider in January. What I'm talking about is what's been looked at as a total payer amount, which is the revenue to be received after billing insurance or billing insurance adjustments for the visit. One of the things that I think help attribute to that, we'll just have to see as it goes over time, but Bill did give the providers an opportunity with allocated hours to participate in HealthStream to review coding. And I think that may be reflected in January. I hope so, and hope it is to continue to be reflected because there was an improvement in January compared to the previous 4 months. Now, if we look at the numbers from August 4th to January 4th, if you want to look at the total payer amount divided by the number of transactions, there was a high, and I'm not going to individualize providers. I'm going to give you the high and the low. The high number was $102.36 per transaction. That was a high. The low, however, was $59.69. Now, keep in mind, some of those have to do with level of care and complexity, but it also has to do something that we're trying to address, and that is trying to improve our coding practices to maximize what we can charge per visit. If I look at January 5th to January 30th and look at those numbers, the previous low from $59.69 increased to $72.59. That was low. The high, of course, the high was fairly high before, $102.36 went to $107.89. Summarizing all of that, we had, counting all 6 providers, the average increase for that 1 month time frame in the transactional amount was 15%, which is a pretty good start. And we'll have to follow that and see if we continue with it, but it's a good start. As we're trying to address how we can expect to increase our revenues, both from increased business and increased cost per visit. But that brings to the point that, and I'm just going to use a general case, we may have one provider that's seeing 150 more patients a month than another provider. But if you look at the net revenue that we're getting for those, it's much, much different. And the provider with the lower number of visits could actually have, and in fact, does have the higher total money per transaction. So it's just something we're beginning to look at and hope to continue on with. And there again, kudos to Dr. Hasty because he's hard on this and providing that. And I think we're trying to look at it in a responsible fashion so we can increase our productivity, but more importantly, what we get paid for. Now, it's one thing to increase the number of visits, but if we're not getting paid what we're due for those visits, we're still losing ground. So that's what we're trying to do. Any questions? Sorry, no slides.
I like paper. We have questions for Doc? Thank you.
Okay, thank
Appreciate
you.
the work there and that in-depth analysis on looking at the pictures.
Okay.
Just to just,
Keep you posted next
basic.
report.
Thank you.
Thanks, Doc. Okay. Next on the agenda is operations report.
I don't have anything to add. The reports were in your packet. If you have any questions, I'm happy to answer them.
Anyone have report or questions? I mean, on those reports?
No, thank you, Bill.
Okay. All right, we will move on to health tech report or health tech update. And if you didn't have the opportunity to meet him when you first arrived, this is Mark Armstrong from Health Tech. He's traveled to spend the week with us and kind of get to know our finance department a little bit. So I'll turn the time over to him. Thanks for being here, Mark.
Thank you. As said, I'm Mark Armstrong. I live in Nashville, president of hospital operations with Health Tech. And it's a pleasure to visit your community and your facility and get to know your people a bit better. I can say that those I've met, I'm very impressed with. There's a distinct sense of pride and ownership. People want to do the right thing. People want to do it well, and they care about what they're doing. And it's been a pleasure thus far. I arrived yesterday mid-morning, staying till Friday mid-morning, so 3 full days. I have worked with hospitals and health systems for 30 years. And I was a CFO and CEO of 2 different community hospitals, public hospital districts. I was also Chief Operating Officer at University of Kentucky, UK Healthcare for 10 years. And the balance of that time, I've continued to work exclusively with hospitals and health systems, and particularly helping them find strategies to differentiate themselves in the marketplace, to remain sustainable, viable, and a relevant provider in the communities that they serve. Sublette Health has done a lot in a short period of time. You have been a busy clinic that decided to open a hospital. It takes a while to get hospital certification. It takes even longer to get a number under which to bill. You became licensed as a critical access hospital. And as Steve showed, your receivables have climbed while you're waiting on all those things to materialize. What's frustrating is you have very little control and even less influence on how quickly those things happen. Thankfully, you are a hospital today. You're going to be getting your critical access hospital billing number soon. That's going to help. Secondly, you converted to a new electronic health record. There's still some bugs to work out for that to be operating optimally. You've got a transition that's soon going to be happening with Bill and Steve both who's done a great job, but they're going to be departing. You're recruiting permanent roles for those positions. So I'm here this week really to work with the team to understand all those moving pieces and essentially develop an inventory of all the projects and initiatives that are underway so that during that leadership transition, we don't lose momentum. We don't lose the pace of progress that's being made. That's really why I'm here this week, is to work with them to, not just Steve and Bill, but others on the team to understand those things. Beyond that, my report will be brief. I want to remind you of the trustee conference that we're hosting in Fort Lauderdale, October 4th through the 7th, that I encourage you to attend. If you've not gotten information on that yet, actually, I don't think we published it yet to board members, but you soon will be getting details on that. That would be a great opportunity to interact with trustees of other hospitals in the health tech network to understand what other hospitals are dealing with, novel solutions that are coming up with things, and just general trustee education. Beyond that, there's been a number of health tech representatives that have continued to interact with members of your team. Just a handful of which Sherry Bernander has met with Vicki, your chief nursing officer, Christina, your compliance officer, on a variety of topics. Marcella Wright was on site here over the last few weeks, last month, I believe, to work with the transition from RN-led care coordination to EMS-led community health integration. And Elreen and Margaret continue to work with a variety of revenue cycle issues, working with Marcella and others. But Elreen is happy to report that the data extraction with the University of Utah is making progress. I think that has been slow to come with U of U and the legacy AR, the data extraction that's needed for that. So with that, again, I'm pleased to be here. It's been a pleasure to meet the folks that I have met. I'm meeting more tomorrow, and I'll entertain any questions or comments you might have.
Thank you, Mark.
Yes, thank you.
Anyone have questions?
What, I guess, does your involvement look like through this transition period for us? Like more time on site, just remotely? What does that look like?
I'm standing in for Dom today, and he's not here because I'm here, and I came to work on that transition plan. I will remain involved as much or as little as the team needs me to be. But certainly my primary role is basically to project manage, I suppose, those initiatives and understand the timelines, that they're realistic but appropriately aggressive, to understand who is ultimately responsible and what barriers or resources they might need to accomplish those objectives. That's my primary role.
Thank you, Mark. Right. Next on the agenda is the CEO report. Mr. Pat.
I'd like to start by saying thank you to a number of people who helped make not only this room, but the dormitory project and the office project a reality. Start with Tyler and company, Tammy and Kevin, Gentry and Marcus, and a lot of other people on Tyler's team. Brett and Matt for the technology throughout the building. So we're going to be able to provide Wi-Fi capability to the dorms so that we don't have to hardwire network connections. And then I really want to recognize Jan. Jan has embraced all of these changes and has been the project manager for it. So just want to say thank you to everyone for making that happen. As you were able to meet earlier, we've successfully hired a new HR director. Ray is here. We're glad to have him. He is drinking from a fire hose. But that is really an important addition, not only for HR, but also for the laboratory, because Sharon will now be able to move back into being only one director rather than two directors. So I'm so glad that Ray is here. So we're working to create the contract that we need for the dormitory, a check-in and check-out process. And we plan to actually begin welcoming people into the dorm by probably the second week in April. So we're very close to having that ready to go. SLT has reviewed and approved a variety of policies. You noted that tonight we don't have any. At your next meeting, we're going to have a shift differential policy for you, a PTO donation policy, a PTO buyout policy, an administrative leave policy, a CEU support policy, and a supplemental staffing pay policy. So
You're gonna make up
There-
for it, huh?
yeah, what the? Oh, and financial assistance policy. And then other policies. So we're, as we've agreed in the past, not all policies are coming to the board. What I'm doing is ones that either are big picture organization wide or money. Those are the ones I'm focused on bringing to the board. So other policies that we've worked on, we've updated the EMS meals and credit card use policy. We're updating the bereavement leave policy. We're creating a without pay policy, creating a working remotely policy, and we're updating our calculating years of experience policy. And then a new one that we're doing, calling it overtime authorization policy. So 2 pay periods ago, we had about $36,000 in overtime. 1 pay period, 36,000. Last pay period, we had 39,000 in overtime. It's important to note that of those totals, about 2/3 of that is EMS. But still, if you factor out EMS, that's somewhere in the neighborhood of $12,000 of overtime for 2 weeks. And so we're creating a policy that is designed to bring the numbers down by having pre-approval. So when people are on call, that's not going to be affected by the policy. You automatically get overtime just because you're on call. When we have needs to fill in call out shifts, that won't be part of the policy because that is an emergent clinical need. But if someone needs to stay an hour today to finish a project, we want that approved before the fact. Because maybe that project doesn't have to be done today, or maybe we can flex time the rest of the week so that we don't have to pay overtime. That's what this policy is designed to do. So when you look at the numbers, 36,000 for one pay period, 39,000 for another, we're just taking that one on. And then EMS isn't immune. So we've had a number of meetings with BJ, Vicky and I, and we are looking at not changing. So I don't want any EMS folks that are listening to think we're changing the 4896. That's a fairly standard schedule, not only for Wyoming, but across the nation. The unique thing about our schedule is the 7th day. So if you work day 1 and day 2, that's your 48 hours. Then you have 96 hours off. So that's day 3, 4, 5, and 6. You work on day 7, all of that is overtime. And so we're going to look at whether or not we can modify that schedule. Now, I know that for some EMS folks, they like that overtime, and I understand that. But from the district's perspective, our ability to afford that overtime on a consistent basis is challenged. So if we can maybe not eliminate it, but knock it down. So we're working hard on overtime across the board. Shifting to medical staff, coming up next week, the 30th of the month is National Doctors Day. And so we're going to be celebrating that. But we're going to be including all of our providers. So MDDO, NPPA, they're all going to get recognized during Doctors Week. So if you get a chance, stop by because we're going to have special signboards around the facility, and we're going to be giving them small gifts as well. So you can't be a healthcare organization with doctors, and we are blessed to have a wonderful team of providers. So we're going to be recognizing them next week. On the recruiting front, we have a very strong physician candidate for one of our new family medicine slots. Remember, we're trying to recruit 4. So we might have the first one. The medical staff interviewed and recommended that we make an offer to this person. So I have, with Lena's assistance, drafted a document that the doctor is now reviewing. I want to highlight the one difference between this contract and the contracts we've had in the past. The goal is to move the physician to what I call a blended compensation model. Right now, we have fixed compensation where it doesn't matter how much the provider works, how many cases they do, how much they bill, they get paid the same. So what we're proposing is that for 2 years, while the practice is building, compensation will be fixed using MGMA averages. And then in the 3rd year, the beginning of the 3rd year, compensation, the fixed compensation is reduced. So rather than going at the 50th percentile, bump it down to the 35th, and then everything beyond that is based on production. So that we're providing an incentive to see higher volumes generate higher charges. We're also factoring in the impact of call within the hospital. So that rather than saying that call is just part of your salary responsibility, we're actually, I've come up with 3 different compensation amounts for a holiday, for a weekend, and then for a normal weekday. So depending on how much call they take, they can make more money. So again, to remove the sting of being on call, you actually get paid a little bit more money. So very anxious. If we can get this one doc hooked and in the boat, that will be a huge step forward. We've identified a locums family nurse practitioner that specializes in women's health that might be a bridge. So she's not interested in a permanent job here. She's from the Cody Powell area. And so I'm going to be asking the medical staff to do a Teams interview with her to make sure they're comfortable with her. And then we can begin the already work of a contract and a schedule worked out. But then we can begin the privileging and all of that so that we don't have much of a gap when Raleigh goes. We've also identified at least one. This is an FNP DNP, doctorate in nurse practitioner, that specializes women's health, but also primary care. So a little bit different model than what we have right now. So if you need to be seen for women's health issues, but you also have a thyroid condition that needs to be monitored or high blood pressure, you'll be able to get that from this one provider. She is a new grad, so she'll be finishing sometime in May, licensure and all of that. She wouldn't be available till probably end of August, early September. She has some unique contract requirements. And so I am working through making sure we can do a win-win contract with her before I ask the medical staff to interview her. Because if we can't do a contract, there's no point wasting medical staff's time. So working on that. And then a new one, a new twist. So I've mentioned to you before that we have had interest from 2nd-year residents, family medicine residents. But we need someone this summer, not next summer. But as I talked to these 2 candidates, they reminded me that during their 3rd year, they actually have a license and can do some moonlighting. And so the model that we're looking at that I want to talk further with the medical staff, I brought this up briefly at BEC earlier this week. What if we were to go ahead and contract with these 2 providers on a limited basis? Say they work 1 weekend a month. We have 2 others. So one doc I mentioned and then one other. And then our model is getting us through to next year. And if we have to do a little bit of locums in the meantime, if we can nail down 2 really strong FP candidates, and these are people that want to work in our model, they want to cover the hospital, they want to work in the nursing home, they want to work in the clinic. The doc I talked to yesterday actually asked whether he'd be able to do some shifts in the ER. So they want the full spectrum of primary care. So we're going to pursue that as a possibility, because if we could, then the likelihood of us hiring 2 experienced rather than 4 experienced is much better than in this model. So just to let you know that that's what we're working on. So the 2 candidates I've talked to, I think that they're great, and I'm going to be asking the MEC to get them interviewed so that we can move forward and see whether that model could work. We're working to recruit our second urgent care provider. Dr. Burnett mentioned that Tara Ryan is doing a great job, and she really has stepped into the middle of it, seeing some really strong volumes. We have changed based on patient input. We have changed the hours. So we were 10 to 6. We're now 9 to 5. But we're looking at hiring a locums PA to provide some coverage, vacation coverage. But the challenge that we're facing as we're recruiting our second urgent care person is a lot of the people we talk to want to work 4 days, not 5. They really would like to work 3, but so we've come up with a couple of options that I'd like to get input from the board on. So option 1, we currently have 2 that we are approved for. So 1 is full, 1 is we're recruiting. And the suggestion was that we restructure urgent care to be 3 12-hour shifts, and then keep in Pinedale and keep Marbleton the way that it is. The problem with that model is that support staff. So, your admitting people, your nurses, your MAs, they all would have to be on 12s. And so that might mean looking at more staff there. And it won't let us bring Dr. Wortham to Pinedale, which I think we are in agreement we really would like to do. That's option 1. Option 2 is that we modify urgent care in both locations and we go to a 4-day week, 10-hour days, and we start recruiting for that schedule. We're concerned about the community's reaction to losing 1 day in both sites. Although we could stagger it some, say that Pinedale is Monday through Thursday and Marbleton is Tuesday through Friday. So there would always be an urgent care open, but it would be still perceived as a reduction in services. It's an option. We want to show you pros and cons. Option 3 is where we, instead of having 2 positions, we add a third. And with 3 providers, we could staff urgent care in Pinedale with 12-hour shifts Monday through Saturday. So we would actually be adding a day. Marbleton would still be on a 5-day week schedule, and we could actually rotate people through. So you could do 3-day week, 3-day week, 5-day week, and then repeat that. So that would be a very attractive schedule, we think. This model also would require additional support staff. And then option 4 is we just keep recruiting for the current model and keep our fingers crossed that we'll find someone. So my preference, especially based on the volumes that we're seeing now in the Pinedale urgent care during what everyone tells me is the off season, and that it's going to get busy as we move into late spring and then through the summer and early fall. Adding a third provider gives us a lot of flexibility, and it may actually offset the need for a PR in person for coverage. I don't like option 2. I don't like cutting a day in either location. So I wouldn't, it's an option, but I don't like it. And I'm not thrilled with option 1. I don't think that it gives us enough bang for the buck. So I'm going to assume that the light is green, but I wanted to talk with you about this before we move forward. So I walked through each of the options, explained pros and cons, explain what my preferences are. I will tell me if you don't want the light to be green. Otherwise, we're going to move forward with changing the model a little bit. And I think being able to add capacity here in Pinedale, which I think will be used, and allow us to have flexibility as far as Marbleton and Dr. Wortham. So I'll pause and see what you think about that.
So which number is it that you're recommending
Three.
again? Number
Option
3?
3,
Okay,
where we add a third provider.
As the provider in urgent care, I also support that option as well, that Bill was just saying.
okay. Thank you, Tara. That was my question, is how does the medical staff perceive these recommendations and what are their thoughts and feelings?
Yeah, and in
about
my
it?
conversations with Ryan, option 3 is clearly the one he would.
Conversations right now have been between Bill, myself, and Ryan. We haven't brought it to the medical staff. It's a good point. I mean, there's pros and cons either way. The easy way is obvious, but it's not the cheapest way.
Yeah.
Um,
Well, and anything that's perceived as a reduction in services is not something that
Well, and
I
the
feel
other,
like we probably want to support right now.
you know, as Bill said, we could option 4 continue as we are and try to recruit the 4th person. I see a problem with that because it may be standard in the industry that 4 10-hour days are the accepted thing. The other problem I have with that is Tara's done a great job, but I worry with that work schedule and that workload about retention. So it's something that has to be looked at there too.
Sure. Anyone else have questions or?
I like the concept of expanding services.
And as long as I say, the volumes that we're seeing off season come heavier season, I think it's realistic to say. And so I'm just trying to anticipate. So I'm not asking the board for a decision. I just want you to know where I'm headed. And if you don't want me to head that direction, you tell me, oh boy. Okay,
There's a number of things to consider, just like, if you're going to have urgent care on Saturday, it's a great idea. It's a great service. It's going to reduce your ED volume as well. Whereas looking at the money thing. So it's complex decision.
Understood. I have
So-
no doubt you'll look at all the factors and
Yep.
try to.
so the last
right
thing under the
direction.
medical staff, Jonathan Said's contract is due on the 7th of April. It does have the automatic 1-year renewal. So from that perspective, we are covered. I've talked with Jonathan. He has several elements in his contract that he would like to have addressed. Coming to the end of a 3-year cycle is an appropriate time to look at things like compensation. So I'm going to begin contract negotiations with Jonathan. And so later in the agenda, when we talk about contract amendments, Jonathan isn't on the list because all of the changes that we're doing for the other docs would automatically be incorporated into his new agreement. On the finance side, we received $5,000 from Rocky Mountain Power. This was to partially fund our recent purchase of the workstations on wheels. We received $2,000 from Jonah Energy to help support our professional weeks or days. So, National Laboratory Week, which was very appreciated, and wanted to note that in the past, many times department leaders were paying for those celebrations out of their own pocket. So we appreciate that recognition from Jonah Energy and thank them. And then wanted you to know that per our contract with Apogee, we've received the invoice related to the recruitment of Dr. Chauskas. Chauskas, Dr. L. And then you had the document on the portal about a proposal to Sublette County to fund the 3rd ambulance. And that is listed as an action item because I'm asking you to formally direct me to present this idea to the county. So the rationale is that if you look at just our volume, certainly for more than half of the year, it might be as much as 8 months of the year, we really only need 2 ambulances for the number of runs that we do. But when you factor in the square mileage and the transports that we do, transports out of the county, if not out of the state, the third ambulance is justified. So for the EMS folks that are listening, I'm not in any way suggesting that we should get rid of the third ambulance. I'm suggesting that it's the county's responsibility to pay for it. That we should be paying for the 2 that I would call volume justified, and they should be paying for the one that I would call as coverage justified. And so BJ and Vicky has worked closely with me. Michelle has provided a lot of data for me. And so we've come up with a number for what it costs us to run a third rig. And in the proposal, you see that I show them the overall performance of the ambulance service. And we are not asking for a full allocation of all overhead and supplies, because when you look at the total cost of the EMS services divided by 3, it's far less than $650,000, or far more, I mean. So we are trying to be realistic in our request, but I think this is a very appropriate. So rather than saying something crazy like we want you to take over the whole service, which personally I think is a bad idea, we want it under our umbrella. We just need help in funding it. And so I would like you to take action and direct me to present this to the county commission. I think that it will hold more weight than rather than this is another one of Bill's wild ideas, that this is something the board agrees with, the board supports, and we would like to enter formal negotiations with the county to support the third ambulance. So the document that you have is the document I would use, and I'm already on the agenda for the meeting on the 7th.
Has everyone had an opportunity to? Questions for Bill?
I have one on the 5-year financial summary. Can you speak to why both the gross revenue and the net revenue has come down time?
So I can't speak to specifics. All I know is that, as Steve mentioned in his report, many times it's approaching half of the runs that we do, we can't bill for. And when patients were transported, but to a clinic, that was not deemed a billable event. So even though it was a transport, we couldn't get paid for it. Now that we're coming to an ED, those numbers should change. But as far as the trend, why it went down over time, I can't speak to that.
So shouldn't we have seen that trend change in the last however many months then?
So I'm not reporting 26 data. This is 25 data. So through June of last year.
And in terms of the unbillable runs, I mean, say the 60-some% that we had last month, is there really 60% of the runs that people are refusing to be brought in? Astronomical. It's shocking, I guess.
I get the number of total runs and the non-billable runs from BJ. I don't know if Vicky can provide any more insight, but
Feature question.
Just trying to understand the number of non-billable runs that there's really that, let's say it looked like the percentage last month was like 65%. So that's 65% of your calls. I mean, because does that 65% of that includes transfers as well, right?
That includes everything.
So if that's everything.
That includes every time an ambulance turns its wheels, whether it's for county coverage, whether it's for a 911 call, a transfer. So I report all of that to you so you know how many times your ambulances are moving throughout our county. Whether we break it down to total volume or just 911 or include transfers, we're about 50-50. And I don't have an answer for you. I wish I did. Like Steve mentioned though, if the neighbor calls 911, or they just want us to come check their blood pressure today, or I fell and I need help getting up. We cannot bill for that unless we transport them to a hospital.
Those percentages similar.
Not really. I would say that in the part of the country I came from, we transported closer to 70%. Depending on time of year, sometimes it was closer to that 55 to 60%, but a majority part of the year was about 70% of transports of volume.
That's not just from January, that, or last month, that's year round.
We've been looking, I've been tracking back, and the billable versus non-billable is something I've been reporting since I got here. But the percentage of transports is something that I've been only tracking the last few months through the slower part of the year. And it's been about 50-50 throughout the last, I think it's 5 months now. I am going back and looking at the retrospective data as well, so that we can look and see how was it last summer, so I can compare to this summer coming, and that way we can forecast and plan appropriately for the coming years and budgets.
Are there more refusals than there have been historically? It almost sounds like
We have a
from the
lot.
information
It really
Steve
surprises
is
me.
giving, there's
Yes,
more.
we do have a lot.
I wonder. Insurance now with the changes. That's what I'm wondering. Yeah.
It makes me wonder. It does make me wonder. And those things, I will say that my team comes back and, Mrs. Smith wanted to go to the hospital by her own vehicle and they mentioned the bill. That's always a concern. And, from my team standpoint, I always tell them, we want to encourage people to go to the hospital no matter what, but if we can get them to go in the ambulance, that's much better. But we don't want to have the financial conversation while we're on scene during an emergency as well.
Absolutely. So it's a piece of community education maybe that. we need to-
Absolutely. I think we can do a little bit better with that.
It's really interesting. I did not realize that that was occurring as much as it was.
It is, and it's one of those things that I'm, how do we fix it, right?
Mhm.
That's always the question. I think Bill asked me that yesterday or the day before when we met. How do we fix it? It's a great question. But we're going to work on it.
I have some thoughts I'd love to visit with you outside of board meeting about.
So part of the proposal is not just asking, but it's also offering what we're willing to give. And so guaranteeing certain things is part of the proposal. So changing to a degree the way that we prioritize transports so that we can almost always assure that we'll have one rig in the county. And in some of the stats that BJ produces, he shows the number of times that we don't have any rigs available or that we only have one. So we're trying to show that we are willing to commit certain levels of support, certain types of support in exchange. So we're trying to have it be a balanced request, if you will.
Will you be taking part in the proposal ask as well, BJ? Will you be accompanying Bill? Not that you're not 100% capable, Bill. I think they'll have questions for EMS specifically.
What happens if we don't?
We're no worse off than we are now. I mean, that's the way that I look at it. So when I'm looking at the overall strategy of how do we deal with our bottom line, this is another one of those big things that could change our numbers. So all you can do is ask. And if they say no, then we're in the same position we are today. The other thing, though, I think it does help to educate the community on the overall level of support that we as an organization are providing to the community and the degree to which we are underwriting.
I think it also speaks to the conversations going on at a larger state level as well with the transformation dollars and how badly those are needed. And hopefully some of these conversations are going on in other counties as well to drive that need home.
So one of the topics I'm expecting to be brought up is the legislation that was passed to increase EMS transport rates from Medicaid to Medicare. But if you remember, that's $2 million for the whole state. So if you cut up our piece of the pie, that's going to be a relatively small amount of money. So that doesn't fix our problem. We're not going to, refuse the money, but just the amount of Medicaid, and it's my understanding that Medicaid isn't a huge percentage of our overall transports.
Well, our legislators certainly need to be hearing from every county about the difficulties with providing standard EMS care and continuing EMS care. So maybe this will filter up.
So as I say, I want this to be more than just Bill's idea. That's why I'm asking for the board to direct me to present this proposal to the county.
Yeah, Madam Chair, I'd offer just a couple comments too. I think the history of the third crew rolls all the way back to maybe the Jonah boom, and we had the county build a building out at Sand Draw and rolled on a third crew. There was a significant amount of there were a lot of cases out of the Jonah field in that period of time. And as time has grown and it's just in a maintenance type mode now. There's not drilling rigs everywhere like there used to be. Of course, there's not a crew out at Sandra anymore. So now here we are. But the comments I would make, right, is just I appreciate your proposal and the way it lays out and all of the thoughts that are there because it captures it all. But kind of the underwriting of all of it is this community value that developed through the safety net of the third crew, right? We didn't turn the third crew loose when maybe the numbers looked like we didn't need them, we kept them. So that's it's an interesting conversation. And I think it's a conversation for everyone in the whole county to talk about is at what cost and where do the tax dollars come from to support the third crew. And I 100% support the ask going to the commissioners and asking them that. But in the background, as Tanya said, there's the greater conversation happening in the state is where's the responsibility lie? I mean, it's the taxpayer's responsibility, but through what mechanism, right? And so, and I gave this kind of point when we're talking about HR policy. When we're flush with money as a hospital district, then it's really easy to just say, yeah, we got the third crew and it's good. But when the revenues are less than they were in 2008 by many factors, it makes it more and more difficult. Now, does the community voice say, yes, we value it and we want it? Then we all need to figure out how to pay for it, right? Where does it come from? And this is a great first. I'm all in. It's great. Thank you for all the work because that represented a lot of work.
So you raise an important point. Even if we don't get a yes today, it begins a conversation.
It does.
Because this may take a while to percolate through all the necessary steps, but at least we can get the conversation started.
It does. And I really, really wish there were press here tonight to write an article about what we're talking about, but there isn't.
Madam Chair, I was just looking at the report and Bill, please correct me if I'm wrong, but is community integrated health what replaced coordinated care? Okay. And so does that have any impact on the transfer request as well?
No, not really. So if you think of it, for the most part, that's being run out of the Pinedale
Okay.
program. And if we have 2 rigs available, we're using one of those rigs to do the CIH stuff.
Okay.
And then the other, so I think of the one rig is the hot rig and the other is the standby rig. Because if the hot rig goes out and the standby rig immediately would say, all right, if I have 2 patient appointments, we're going to reschedule those so that they can move and be ready to go.
Okay, so it's not impacting things on that level.
It should not, no.
Okay. Thank you.
I guess I would just like to know kind of everybody's thoughts and comments in terms of, support from the county on when we started this whole project that they gave certain things so that we could stand on our own feet. So I just have a lot of concern that, we come back and start asking for more. I mean, I completely agree with Jameson's comment in that, whose responsibility is it, right? And I think that that's the important question. I just I don't know, I have a lot of hesitancy going and asking for this. Agreed, but the county's feeling that as a whole too, so is that fair for us to ask for that? Do you know what I mean? I don't know.
So part of the way that I look at this is if we're going to run ourselves strictly as a business,
Mhm.
then we're going to look at volumes and we're going to adjust our services based on those volumes.
Mhm.
But if we are going to have a mission element to our presence, to the services that we offer, then at times we're going to do things that aren't financially viable. And the question is, how is the community willing to support that? So even if we were to only run 2 rigs, the service would not be profitable. But the third rig clearly pushes us into an area that I would argue is mission driven, not financially driven. So if the community wants us to be more financially driven, then they have to accept that there are choices that go along with that. So the discussion we had earlier about urgent care, one could argue that now that we have the ED, we could run a fast track program through the ED and not have an urgent care program. I'm not suggesting that. I don't think that's the right thing for us to do today. But that's where the balance between just looking at the numbers and looking at what the mission is for the organization, there's
Mhm.
got to be a balance there. And the county, as responsibility for the entire community, I think needs to have a part of this.
I guess one other thought or question is, do you think that the residents of the county are going to say, I'm already taxed for the hospital district? And is that is that what that's going to? I just see that being an argument.
And I can
I mean-
appreciate the argument.
But obviously we provide a lot of services and that only covers so much, right? But is
Right.
that how that's going to be perceived?
So one thing that when I've gone to meetings, has always come up is, are we present at rodeos? Are we present at high school community events? Are we present with the community integrated health? What are we doing to give back? I think this proposal actually supports us continuing to be able to do those community events. And that's where we're asking for that request. Because if not, it's like what Bill says, you have to go to a business model, and the amount of mileage that we have in this county, I don't think we'd be able to do the community aspect and also the business if we don't ask for the support. And it's always one that comes up. Are they going to be at rodeos? Are they going to be at special events? Are they going to be at games?
I think you probably have a pretty good idea of where I stand on this, at this conversation for a long time. I hate we're having the conversation. It makes me ill that we have commissioners, but I also have had to look at our finances pretty carefully and pretty in depth, and the struggle we've been through over the last few months and year. And I think that I don't know that the answer will be affirmative, but I think it's necessary to start the conversation. Had to wrap.
Madam Chair, just one comment. I think it would be important for you to prioritize or ask what your anticipated ask are or might be. Because if you come forward with this one and get it turned down, the next one's going to be even slimmer. So it's just something for consideration.
Certainly a valid point also. Okay.
Question. So Stephen, in terms of finances and comments that you made earlier in terms of what your original estimates were, and that some of those are looking better. Do you think by the next budget, you're going to have a better idea at where some of those things are going to land and have a, more closer picture of what our financial situation may look like in the coming year, 2 years?
Yeah, excuse me, EMS is reimbursed differently. So it's not, the critical access
Yeah.
component doesn't have the same impact in the EMS arena.
And I think I'm talking like overall financial health of the organization.
Well, certainly any money that comes from the county is going to help.
Well, I mean, without that though, like
Yeah,
based on current timelines, like when do you think that we'll have a better idea of?
yeah, we're working on the budget right now.
Okay.
And my request to the department manager, so everybody's involved in this budgeting process. It's just not me coming up with a budget. So
Mhm.
managers are going to be providing volume expectations, whether that's an increase or a decrease, staffing, overall expenses. And I've asked for all that data to come back to me by Monday of next week. Next week, the 30th. Yeah. So very rapidly, we're going to put an initial budget draft together, and that will help me understand where we're at a little bit better than, the dart throw that I did based on my experience for the revised budget for this year. But there were a lot of factors that have changed, and we anticipated those changes, the critical access component and some of the other expenses like the ED physicians and the Apogee contract and those kinds of things. So we'll incorporate all of that, and hopefully within a couple of weeks, I'll have a better baseline to work off of and try to understand what that's going to mean for the organization from a bottom line standpoint. So I've been hesitant to try to do a lot of forecasting on my own without that data from the individual department managers, but that's coming very quickly, and certainly will be done before I leave at the end of April.
Okay.
At least the first pass.
Okay.
But to your global question, what is the financial future of the organization? Didn't say it that way, but I think that's what you're getting at.
Yeah.
Even with all the positive impact of critical access, if you look at predictions from the revised budget, so 5.5 million EBITDA, so 5.5 million to cash is the current loss. So that would just bring you up to barely a break even as far as cash. The overall loss, if I remember right, is something in the neighborhood of $10 million. So the prospect that on our own, we're going to get to a break even, not EBITDA, but break even in the next fiscal year, I don't believe is realistic. And so finding other infusions of operating money as opposed to capital money, I think we're going to have to be creative. And I kind of appreciate that the history that you've gone through with the county. I'm not affected by that. I don't have that history. What I'm working from is the responsibility that I'm used to the county having within its community and the funding that it should provide. And that's why I'm not hesitant to make the ask. I think that it's a very reasonable thing. I think the proposal we put together is a balance of what we're willing to give or assured that we continue to give. And I think it clearly justifies something that is not a want, but a need for the community. And I get where it came from. But I would argue, even without the volume that used to be there, the number of miles we're responsible for covering, 3 rigs is the right way to do it. So, if you don't want to do it, I understand. But I would argue it's a missed opportunity to, at the very least, begin a conversation that I think really needs to be had and is part of a larger context of who is really responsible to provide this service. we already know who's supposed to provide law enforcement. We already know who's supposed to provide fire. We don't really know who's supposed to provide EMS. And I think that is a statewide conversation. But I don't see any reason why we need to wait for that to get done before we can start on our own.
Bill, a thought just occurred to me, and I don't even know if it's worth having the conversation, but we cover Labarge as well, which is Lincoln County. We do that because we're neighborly and that's the way we operate. Is there any value in approaching Lincoln County and asking for their assistance to help cover costs? I don't know what that would
I'd
look
be
like,
happy to
but
do that. The other thing that I'm expecting them to say is, have you talked to the oil companies, for example? Who else have you talked to? And I'm going to say, I'm starting with you. But if you have other people you would like me to talk to, I'm happy to add them to the list. And so in county, I think that's a great one. I think the oil companies, because if we can do this as a coalition, maybe it has more odds of success. We're not even talking about it though, and we're not going to change where we are today.
Is there any potential for starting the conversation without a specific ask?
Without a number?
Mm.
The first question I would ask is, how much do you want? So,
Fair.
and I work from the position you can never go up. You can always go down. So if we ask for 650,000 and we get 300,000, I would count that as a win. That's part of the negotiation from my point of view.
maybe that conversation just even rolls into you provide a new rig every 2 years and we'll staff it or something along.
Right,
those
there are
lines.
other ways to look at it. Yes.
Out the data and without the numbers, we don't really have the ask, though. So I think the numbers help support the ask, start the conversation.
Bill, the next item on the agenda, is that something that will be a county discussion as well?
Yes. So that's actually, I was going to talk about the meeting with the Bank of Jackson and then go into the next one.
Okay, I just wonder if it, before we take action on this one, if
Okay.
it would be helpful
Sure.
to everyone to have a more global conversation about where you're headed with some of those things. Would that be okay with you?
Sure.
Or if the board prefers to take motion or take action on this?
I think it's a good
To
idea
hear.
to have complete context. So Steve and I met with officials from the Bank of Jackson. It was a very positive meeting. They continue to be very supportive of our organization. It's clear that they are willing to be as flexible as they can as it relates to the line of credit. But the one thing that they can't do is they can't allow that debt to go more than 1 year. That gets into issues with bond covenants. And so we are going to have to figure out how by June 30, we pay $8.5 million. And so that then led to multiple conversations that Steve and I have had. Where could we get $8.5 million? And one of the things that occurred to us was we've got a receivable on our books for $6.1 million. So based on the way that the tax laws changed, companies can defer taxes over 13 years. So we currently have 6.1 million on our balance sheet that we are owed over time. And so this idea is that we would sell that receivable to the county. So this one, we wouldn't be asking for a donation. They would actually be getting a tangible asset that would be equivalent to what they're paying for it. So not wanting any sort of discounting on it. So 6.1 million, they're going to buy it for 5. We need the 6.1 million to use against our 8.5. So if we could get the 6.1 from the county, then I believe on our own, we have a much more realistic opportunity to come up with the balance. And so that's what that one would be, to enter into negotiations with the county to sell them a 6.1 million receivable that we have on our balance sheet. And then they would be responsible for collecting it over time. And we would use the proceeds to pay down our line of credit. So as soon as a deal is consummated, we would pay that portion of the line. And then by the end of June, we would find other mechanisms to come up with the difference.
What type of impact would that have on our monthly mill levy payments? I know not all of those are deferred, so do you have any idea?
I don't
What-
have a number,
what
but it's
portion
my
of that?
sense that it's a small amount
Okay,
comparatively.
okay. That's what I wasn't sure about.
So I'm really confused a little bit, and this was probably prior to you, Bill, but I recall asking very specifically months ago what the consequence was of carrying that balance on that line of credit from June 30th to July 1st. And I felt like the implication that was given to the board is that it really shouldn't be a problem. Anybody else remember that as being the case?
Statutorily, it cannot happen. Statutorily, it has to be paid off, but I think my understanding was there was some mechanism by which we felt like Bank of Jackson Hole work with us to make that switch somehow. And we didn't know what that would look like. And having that conversation, I don't know that that was clear to any of us. That was my understanding. Conversation.
When we met with Bank of Jackson, in a lighthearted fashion, we suggested that we could cut them a check on June 30. They would put the check in a drawer for a week. We would redraw the line on July 1 so that we would have money to cover that check, and then they would deposit the check. I'm sure that that's not in any way appropriate. But you know how, as an individual with your rent when you were young, you played afloat? And unless there's something like that that's possible. There are other, could we identify someone who is willing to donate that amount of money? I'd say that's a really, really long shot, but not to say that we wouldn't try. But from our own resources, I currently don't see a way that we can marshal $8.5 million.
Mhm. So I guess my question is statutorily, like, what happens? Do they come in on July 1st and close our doors? Like, what actually happens? What is the consequence?
So we didn't go that far with the conversation with the Bank of Jackson. That, I believe, I would want Lena in the room to have that conversation.
I just feel like that's quickly coming, and even though that's a hard thing to know, we need to know what that is.
I
we
don't
don't-
disagree. This
I know.
idea is a way to,
Try to.
so again, that's on the agenda for the meeting on the 7th. I would like to be able to say that I have direction from the board to approach them to negotiate the sale of that asset. So, no, you ask whether I have a document. Right now, this is just a concept.
Understood.
So I would want to talk with the county finance people. We'd certainly need to have legal involved. A lot of work would have to be done, but conceptually, are they even open to talking about it?
Conversations have been had previously in this regards, Bill. I know that when the deferments first went into place and when we were having these conversations 2 years ago, it was indicated that the state might step in and provide loans, low interest loans for facilities who would be significantly impacted in a negative way by the deferments. But those conversations kind of fizzled, and I'm not sure where they went, but we're seeing the impacts now. So.
Madam Chair, correct me if I'm wrong, but we can't have any more debt for our bonds, correct?
No formal debt. That's why the line of credit needs to be less than a year. Then it doesn't qualify as debt.
Okay. But when you were talking about from the state level on loans and that would be qualifying as debt.
Right. So as Steve and I have talked about this, all the other options that we have identified are debt.
Right. Because I know we talked about, and this was a question that came up when we were discussing the line of credit was, okay, when that fiscal year comes, when do we have to start that application? So that way, when it's paid off immediately on July 1st, it was presented as there was a mechanism on the back end of that. So I do agree with Ashley. We need to know kind of the repercussions of that.
And so I can work to begin to find that out.
Okay.
To go back to, I forget which mentioned it. I think you mentioned it. An understanding previously that it wasn't going to be a problem. Part of what I understood was that the assumption of critical access conversion would have happened and that the benefits from that would have provided proceeds to help pay it back. I'm not sure that I agree with that assumption. Certainly based on where we are today, we had full effect of critical access. That wouldn't generate the cash that would be necessary in the half a year's time, say, for us to be able to pay that amount of money back.
And that was a question that we asked because we were talking about worst case scenario, getting critical access, even where we're at right now. That was one of the questions we asked in regards to this topic on being able to pay it back with critical access.
How much does current AR play into that, or does it?
The faster we can collect some of this backlog that we have been billing, that will help, but it's gonna,
Obviously
I
not.
mean,
enough, but-
even if we were able to bill all 13 million of our backlog, we're only gonna collect maybe half of that. And it's not all gonna happen all at once. And we'll still have operations that we have to pay for going forward as well. So it could impact maybe $1 million, $1.5 million. I haven't run any specific numbers, so that's just a dart throw on my part here, but it's not, and that's part of the other mechanisms that Bill's talking about to cover the remaining 2.5.
Of that 13 million, how much of that is legacy? Just
About
refresh
$1.5
my
million.
memory. So less than where we started.
Yes.
It's a good thing.
Yeah.
That's significant, but it will still take months to get
Right. And
these monies.
you
in the
know,
door.
that's at the gross level, the $1.5 million, the actual collectible, I'm already estimating that we're only going to collect at the most 20% of that. And a variety of reasons, timely filing is probably the biggest one. Medicare, we have a full year, but commercial insurances are usually 6 months or less. And we're way beyond that for legacy stuff.
Bill, would it be possible? So kind of going back to what Doc mentioned is prioritizing what the request is. To me, without knowing that information, I'd say the request needs to be the account receivable. Because that's more important right now of whatever the consequences are by us not doing that. Is there any way to get that information to us for us to review to make that decision before you're on the docket for April 7th?
So to find out what happens if we don't pay it? Is that,
Yeah,
I mean, end of the chase?
yeah,
Yeah.
essentially.
I certainly can reach out to Bank of Jackson tomorrow.
Okay.
And begin getting that question answered.
I think that would be the first step on us being able to make a decision on either or. We're missing, I feel like, key data. 650,000 is a lot different than 6.1 million.
They're not giving us this.
Right.
line or receivable.
Correct, but they may not see it that way. Because they now have to go collect on it. For it to be paid back.
And I imagine those would come out of two different buckets of their money.
Are
Right.
we suggesting that we have to achieve one of these? Shouldn't go.
No, I'm not saying one of them. I was just more or less taking Doc's advice on,
Was exactly.
Prioritizing.
Need to prioritize your ask. It's gonna be hard to go with them to come to agree to one. If you go with them two, your chances are gonna be even less. If you go with them to one request and then come back 2 weeks or 4 weeks later with another request, your chances of moving forward are gonna be even less. That's just how they operate, how they think.
Suggesting. we do.
Prioritize your ask. Which one is?
But only ask for one, not go back for a second, or
Yeah, and I think Ashley's right on track. You need to see what the impact is of the 6.1. Granted, they're not loaning you that money. You're just selling them those receipts, so to speak. But they're going to look at it as you're asking for help. And in order for us to provide that help, we have to do this. Does that make sense? I mean, it's just the mindset. And of course, it is coming budget time. If you're looking at the second ask, which is the 6.1 million, you can make the argument that you're just helping us get the money that's deferred to us, and you're going to get it anyway. We're not asking any money out of the county coffers, and it's a hardship type thing. So it might be an easier sell, but trying to do both of them at the same time is going to short circuit some of their minds, I think.
Madam Chair, I got a question.
Sure.
And I don't mean to interrupt the good conversation, but I just would ask Steve and Bill if maybe there's an opportunity to change vehicles right now. So a little bit of research I did on the critical access hospital, the way it works. So interest, right? You get whatever your percent on your payer mix, they pay that interest. So early in a mortgage, right, your interest is high. And so at this period of time when we're young, it would be to our advantage to, if we had a mortgage for all of it, right, for $40 million, we would have to make other decisions later as the principal starts being more part of the payment 20 years, 30 years down the road. Is there an opportunity to change vehicles at this point? Could Bank of Jackson Hole fund us $40 million and we can close our construction and close our line of credit and make a big payment to Bank of Jackson Hole?
So that would be question two. So question one to Bank of Jackson, what happens if we default on the line of credit? Question two would be, do they have an appetite to fund the entire construction loan potentially?
Interest rate today is 6.75%.
But right, I get it. We let go of that low interest rate, but with the critical access, the way the strategy works, doesn't affect us as terribly today as it does in the future. That's glossing over a lot of stuff, but
I mean, it certainly is a question that it doesn't hurt to ask. I would guess that they don't have the appetite for that amount of debt on their own, which is why programs like USDA and HUD exist.
Right.
But I'm certainly happy to ask. And it actually may be an important question as it relates to question one.
Right. I think your point on the interest is super important, but at the same time, depending on what the answer to question number one is.
So the other consideration, and I don't mean to put too much emphasis on this, but I've got two opportunities to talk to them, 7th, the 21st. And then I'm gone. And so I was wanting to maximize my opportunity to work on the relationship that I've built with them. That was part of my rationale.
And I agree with that point.
Yeah.
I think you built good rapport with them. I just think we need some questions answered. I'm willing to, for the 7th, be able, if we have some of those questions answered, give you some direction afterwards, depending on what those are.
So with that in mind, I will work to get both questions answered. And then as soon as we can, we could convene a special board meeting to talk about both of these topics. So for tonight, table both of these topics.
Yeah, yeah, we could do that with a motion. I would just add that I think that conversation was had with Bank of Jackson Hole prior to obtaining USDA funding too. As I look back, I think that question was already asked,
I wouldn't be surprised.
so wouldn't,
Can't hurt to ask.
doesn't mean we can't do it again, but they don't. So. Okay, given all of this discussion, they're just like to table and plan to meet next week at some point early in the week as a special meeting. Or does anyone want to take action on any of the items as recommended by Bill? I know, be a tough week. Guys in tough.
I can always do a team meeting. Get the answers first. Personally,
I'm sure going into that next week, could you provide for us, Bill, that $6 million looks like the consequence and how long it lasts? And we're not selling it at a reduced rate, right? It's a dollar for dollar.
That would be my proposal. There's no discount. That defeats our need.
Can we, is it possible to project how that $6 million is going to come in?
Over the 13 years.
Yeah.
I don't know whether Steve and Michelle can put that together. We'll certainly try.
I'd
Yeah.
like to see that monthly impact just to know.
I don't know if you recall, this was one of the discussion points at the audit review last month, and how it was calculated and how it's changed over a period of time. It's not interest bearing, so we gain no interest on it. It just sits there as a receivable. And same with the county. I mean, the county has their portion too. So this would just be transferring our portion back to the county.
So Jan notes that documents that we want to have the commissioners consider have to be provided to them by the 1st of the month in order for them to be on the agenda. So absent a decision, the topics could be there, but I wouldn't be able to have a formal this proposal to present to them. So I could talk about it, but they wouldn't have a document to review after the 1st. I think you still need to try and get the questions answered before you can go on record.
if we were to meet 1 week from today, that puts it on the 1st. Could you have, couldn't do it?
First is
Met it right
Wednesday.
now? Is
Is
Wednesday.
Wednesday.
So if we met next Wednesday, would we be able to still get them document? Or it would have to go
Probably not.
technically the following day?
The proposal, unless you were to suggest edits to it, I'm ready to submit it as it's currently drafted.
Okay.
So it would be ready to go. So if we were to have a meeting earlier on the 1st,
Right.
then later on the 1st, the document could be provided to them.
We could meet earlier. Concerning Monday or Tuesday. From those logistics. Direction. It would be my preference that we table it at this point. I don't know. Would be my preference that we table both of these items tonight. Gather a little more information. Come back for discussion. Possible after some answers can be.
Is my preference as well.
So if it's on the agenda, do you have to do something about it?
Yeah,
So
it's
you would have to
specified
table
as an action item as well.
Okay.
So we would need a motion to table.
Madam Chair, I would
Any-
make a motion to table both items 1 and 2 EMS support proposal and selling the deferred tax accruals.
Okay, we have a motion
I'll second.
and a second. Any further discussion? Right, hearing none, I'll ask for a vote then on the motion as proposed to table items 1 and 2 under CEO report, EMS support proposal, and selling deferred tax accruals proposal. All those in favor, please say aye.
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 Any opposed? Motion carries.
Thank
I'll
you.
connect
Then
with
I
you
have
and
just,
schedule another meeting as
Yep.
soon as we have. more
so I'll
information.
get on it in the morning. As soon as we can get answers, then we'll get something scheduled. Okay.
Thank you, Bill.
Then I had just two other items, since we were in the middle of my report. One, we had a complaint from CMS back in November. I had reported to you on this. It was where someone had complained that we weren't properly following the good faith estimate requirement. We have worked with CMS. We've made modifications to our processes, and we received a letter recently closing that case without any penalties or fines or anything. So I wanted to close the loop on that. And that's all that I had in my report. I do have a number of executive session topics to bring to your attention.
Any questions for Bill?
I guess I just had one kind of question slash request and maybe to Bill and Mark, but with some of this discussion that we've had, I hope those things are on your list to bridge this gap. Thank you.
Any further questions for Bill? Right, let's move on then. Old business, approval of payroll and bills.
For the month. Fixing the amount. Some $6.
You Kenda, we have a motion. Second, from Taylor. Are there any questions, comments? All in favor of the motion to approve payroll and bills in the set forth amount, please say aye.
Aye.
Any opposed? Motion carries. And that puts us into new business. First item on the agenda under new business is the 307 air rescue contract. It's been provided to everyone. And I will let you speak to that one, Bill.
Okay. So we have finalized our negotiations with 307 Air Rescue as evidenced by the contract that you have before you. Our team was actively involved in the negotiations. Lena was actively involved. As part of our due diligence process, we made sure that any costs related to this project had been clearly identified and the responsibility for them spelled out. And for the most part, The district will have no costs other than sharing half of the cost of installing a fence. And the thought is to do that in the fall, after we have a little bit of practice with the helicopter on the pad. There are legal risks related to having the helicopter stationed there most of the time. As is referenced in the contract, we will have coverage through the company, but we have looked at what it would cost to have our own policy. And we've got two different quotes. One quote is for right around $5,000 a year. It does not include any injuries related to the helicopter itself. So if someone were climbing on the helicopter and fell off and injured themselves, we would not have coverage for that. The second policy is a little bit over $11,000. It provides coverage of that type. And so that would be part of my intent that if this contract is approved, we would buy additional coverage for the helicopter, not to exceed $12,000. I think that that is a very conservative thing for us to do. As we've looked at it, there are clear benefits to the organization and to the community. The community will see the addition of a number of well-paying jobs, pilots, the flying nurses that would be stationed here. The benefits to our patients are clear. There will be reduced response time whenever a patient needs to be flown. And what we have seen even recently is where we need to fly, but they're not able to fly from where the helicopter starts. And so by having the helicopter start here, we're going to have the opportunity to transport people more consistently than we can today. And it may mean that instead of flying west, we fly east, but at least we can fly. We haven't identified very many potential negative issues. Clearly, there's the risk that if there were a mishap with the helicopter itself taking off, landing, that sort of thing. We've identified that there's not a need to have fuel on site. And typically that would be one of the risks that you'd be looking at. The only risks in my mind would be potential misperceptions. How is it that the hospital can afford to have a helicopter there? So part of our job will be to communicate to the community that this is something that's being done at very minimal cost to the organization. It's not like we bought our own helicopter. So from my perspective, there are huge upsides. There's not a huge cost impact. And I believe this has wonderful benefits for our community. So I would encourage you to approve the contract that we have proposed for 307 Air Rescue.
One quick question, the question I always ask, but there are some edits in this, so I'm not certain we got the final draft of the contract. Has it been reviewed by our legal counsel? And
Yes, it has.
okay, just wanted to make sure. Thank you.
And their legal
Multiple times,
counsel as
Madam
well.
Chair.
Okay, thank you. I thought so, but I just wanted to ensure. Does anyone have questions about the contract? Kind of had some earlier conversations about it, so I think everyone's fairly comfortable. With that, I'll just open the floor up for questions or concerns or action from the board.
Chair, I would move to approve the contract with 307 Air Rescue.
Thank you, Kenda. We have a motion.
I will second.
Second. Thank you, Ashley. Any last minute?
Do we need to include the portion about the insurance not to exceed 12,000? Part of that or no?
I don't think it needs to be part
Okay.
of that. The minutes would reflect it. Do that.
Thank you.
Any other questions? Right. On the motion to approve the 307 Air Rescue contract, all those in favor, please signify so. Aye. Any opposed? Motion carries. Okay, Thank you. Thanks, ladies. Next item under new business is provider contract amendments. So, Bill, I'm assuming this one's yours.
So there are four different, actually 5 different topics that we found needed to be adjusted in our provider contracts. The first one was related to a provision in the contracts that the providers would get a discount on healthcare services provided by the district under our insurance. The current wording puts us in violation of some of our payer contracts because it could be interpreted as giving a discount off of gross charges that would bring us below what we charge the company normally, and they never want that. They always want their charge to be the lowest. So the revised wording still offers the discount, but in a way that is compliant with the contract. So basically it says rather than off the gross charge, we're going to bill it, whatever copays and deductibles are required are paid, and then the net gets the discount. So that one fixes that. We've already touched on this and have fixed it in a couple of the newer contracts, but some of the contracts have wording related to the health savings account, and it provides a higher level of benefit than we offer to our other employees, which can easily be seen as being discriminatory. And so the revised language standardized the benefit and removes that legal risk. The third topic is CME funding. The current wording in a number of our contracts includes the requirement that things like medical license or the DEA license are part of the CME funds. So we standard pay $5,000. DEA on its own, I said DME, it's DEA, is like $800, $900 every 2 years. That's a significant part of their CME budget for something that we require them to have. So the new language breaks that out. So from the provider's perspective, it's a much cleaner approach. All of the expenses that are required are separate from CME, and they have the full $5,000 to use for education-oriented expenses. Number 3, PTO. So the current wording in some of the older contracts is all over the place as far as the amount, and some have carryover language, some don't. So the revised language references existing policies, the policy that you just approved. And again, it standardizes that across the board. And no one, especially with the addition of the CME PTO benefit, no one will see a cut in their PTO from this approach. And then the last thing, and this just came up this week, was the question of the wording related to incentive bonus payments. So what happens if someone is here a partial quarter? How is that figured? And so the new wording says that a partial quarter, either when the provider first starts or a partial quarter when the provider leaves, aren't included in the calculations. It just cleans things up. So those 5 different elements. So what I have for you is that not all of our contracts needed all 5 elements. So Dr. Ader needed all 5 elements. Dr. Hasty needed all 5 elements. Dr. Wortham needed all 5 elements. Noah only needed elements 1, 2, and 5. Ryan needed 1, 2, 3, and 5. Cassandra needed 1, 2, and 5. Tara needed 1, 2, and 5. Chelsea needed 1, 2, and 5, and Corey needed 1 and 5. So those are the amendments that Lena has helped me draft. This will clean up non-compliant or non-consistent, both ways, aspects of our contracts. There are still other elements within the contract. So for example, compensation. This doesn't touch compensation. This is largely related to benefits, but it's an important step forward. Medical staff has been briefed on all of this at MET. I talked about the 2 most recent ones, the one related to the incentive pay and the one related to the discount. They felt like the proposed wording was very appropriate. So I don't think there's going to be any issue. The medical staff knows that this is being proposed, and we'll be able to get it cleaned up within a week or so.
I appreciate the standardization. I think it's really critical as we work through all of our processes. So thank you.
Madam Chair, if I could just make a point of clarification.
Please.
Bill mentioned 9 providers, there's only 8 on the list. I think it was just omitted Corey Wins's name on there because he did mention Corey in his report.
Oh, yeah, she's not on the list though. Thank
She's
you.
on mine, sorry.
That's okay. That's okay. You did speak it, so thank you for the clarification though. Okay, so in the terms of action, you are just looking for our approval for you're moving forward with amending those contracts as stated.
Right,
Correct.
you're approving those amendments, correct?
Yeah. Right. Anyone have any questions for Bill about that process? Someone like to make a motion in that regard?
Madam Chair, I would make a motion to approve the provider contract amendments as presented.
Okay, thank you, Ashley. We have a motion.
I'll second.
Second by Taylor. Any further questions, comments? Anyone? All in favor of the motion to approve the provider contract amendments as presented, please say aye.
Aye.
Any opposed? Motion carries. Thank you, Bill.
Thank you.
Last item on new business is FOIA requests, of which we have none this month, none that I've been provided, so we will bypass that. And that puts us at the end of our regular business, and we do have some executive topics to discuss. I believe there are components of all 4 topics tonight that we have some brief discussion at least in all 4 regards. So if someone could add that to the motion, I would appreciate it.
Madam Chair, I would make a motion to go into executive session for the purposes of personnel, real estate, CEO contract, contracts, and legal.
Okay, thank you, Ashley. We have a motion.
I'll second.
And a second. Any further comments, questions? All in favor of the motion to move into executive session for those purposes, please say aye.
Aye.
Any opposed? Motion carried. Thank you. Thank you all for your reports and your time. Yes, very, very much needed.